So you are aware that since our last session, we've had a pretty big change at our company. Our Therapy Source, Rehab Toolkit, and Revenue Cycle Services divisions were acquired by Kasamba last month. Teams are extremely excited for change and to be able to fully commit to serving the therapy industry and to being able to offer expanded solutions to therapy providers across the entire continuum of care. Hasn't changed is we're still guided by the expertise of a familiar face and voice to most of you. Our host today, David McMullen, the newly minted Vice President of Products here at Kasamba, is a PT with more than 20 years of experience in a variety of healthcare settings, and he was integral to the development of our Therapy Source software program. You may also recognize his work from various industry publications, including the most recent issue of Advanced for Physical Therapy and Rehab Medicine. So I will turn it over to David to get you caught up on the latest. David?
Thank you. I appreciate that. Am I coming through clearly? Great. Welcome, everybody. It's hard to believe it's the middle of November, and Thanksgiving's a week away. So, a lot of material, about 39 or 40 slides to cover. So obviously a lot of things were finalized just within the last 30 days. Several things we expected, some things we didn't. And we're going to kind of dive into all of that. Focus a little bit of ICD-10 update that I'll cover with new codes that went in place October 1st, and then MACRA published the Quality Payment Program final rule too long ago. We'll talk about that. We want to keep our eyes on that ball. It's definitely paving a path of where we're all headed from a therapy perspective. And then the Medicare Physician Fee Schedule final rule that came out just within the last 10 days or so. A number of key aspects of that. Not a lot of surprises. Been a proposed rule, but we'll cover a number of those, and then resources they'll get into. Before I get content, I always like to make sure, as a disclaimer, that really recommend that I love providing this information to you guys and doing it at no cost to you, to give you a good overview of what's happening, and also really to point you to the sources of truth for all of these things, because I interpret these things, I read these things, I make comments but again, this is just one man's opinion. So I really recommend that you go to the sources of the truth. There's some other webinars, et cetera, that are good to attend. There's several coming up between now and the end of the year, obviously with the fee schedule. That I just really recommend you do that, right? So again, one man's opinion, not the gospel. Really seek out additional resources and go to the resources that I've attached at the end, which is the real sources of truth for each of these components. So with that, let's get started. The ICD-10 world, well, there was a pretty update in codes that we just experienced in October 1st. And one of the things that nature is you don't know how good you have it until something changes. Well, I don't know if we realized how much grace we were being afforded in the first year of the ICD-10 implementation until it was removed. So a fair amount of code changes. Obviously, we talked about, I think, in the second or third quarter update, that the code freeze that had been on for several years was removed, and this was the first big update. And then we're pretty significant updates to the codes themselves, as well as refinement to the whole goal behind ICD-10, which is a lot more specificity around coding for the individual impairments and the patient as they present, drive data to be able to drive a number of things. And so with them, there was a number of codes deactivated, there was some new codes activated, and there was a number of changes made to the codes. And into that, all of the sort of the grace period wasn't just the free the codes. It was basically nobody's penalized for maybe not picking the most accurate code, the most having the appropriate code in the right spot, meaning the primary diagnosis, and you picked a code and maybe you didn't have the laterality correct, or you didn't have laterality where there should have been a laterality component, except those kind of no harm, no foul for over a year. But that was sort of staying on top and managing that and monitoring that. On October 1st, you might have seen a number of changes or a number of issues with regards to claims and denials, on top of that. So it's not too late to really jump in and address that and fix that, and know that next year, October 1st, 2017, there's going to be a whole lot more codes. They're going to continue to refine this and more specificity, et cetera, in each area, particularly when it comes to the areas that, of your scope of practice. I'll talk a little bit about that as we get into this. So it's sort of the grace period ended October 1st. And so for a lot of us, that may have had an impact. There's obviously one of the unique things about our space is, unlike the physician space or some of the other healthcare verticals or delivery models, we see patients right over the course of a time. So we were probably seeing patients in September, and we're still seeing them in October. So what might have not have been denied, say, in September 20th, and all of a sudden you see them on October 3rd, now you're getting denied. Same diagnosis codes. Well, you've made some unspecific or unspecified codes that should have been a lot more specific. You may have an order in which the principal diagnosis should have been the primary, and you did not have it that way. Or you might have inadvertently chosen a code that was deleted, changed, or inactivated, right, or modified to have a more specific code. And, the local determination and national determination edits, kicked in, and there was changes to those edits through the course of the year, et cetera. So all those things were drivers for what we were seeing of increased denials, and talking to some of our big clearinghouse partners that were driving a number of these things, and you really need to be looking at that and managing it, monitoring it. And I always recommend that always up to that October 1st next year, be doing some assessments and looking at denials and looking at clinical documentation and behavior on coding, particularly on the ICD-10 side, prior to this, because when you go into that transition, you want to make sure you're making the appropriate changes with those that are changing, because they published them earlier in the year, right? So specifically to sort of the therapist world, here's some of the codes that, new codes or codes that changed. And so we had about, a little 2,000 new codes were added, and we had 500 or so codes that were revised and about 300 to 400 that were deleted. But, some of the ones that may be more interesting or specific, with the patient types that we see. So carpal tunnel syndrome bilateral was a code that was added. They had a lot of specificity around the sequelae of from a CVA or cerebral vascular disease. And I just put just a snippet in there, but there's a number of 6 character descriptions and for cognitive deficits that were added to make that really, really a lot more granular than it was. Another big thing that might have impacted us from the PTOT and in the hand therapists is pain in the hand was previously indexed to M79, and now it's M2554, and again, that specificity coming in there with the laterality component. So those are things that may have caught you off guard. The other big one we saw a lot of was the cervical disc disorders, because we see a lot of neck and back patients on the cervical side. That was expanded in the mid-cervical disc range to specify, each of the levels need to be with those codes. Those are all things, new codes that were added, that if you were using those or you needed to start using those, or maybe an update or change those patients who crossed over during that grace period change. Revised codes, because a lot of us in rehab, obviously we deal with concussion, or been dealing more and more with concussion. So there's some revised codes in the concussions, as well as a number of codes that were there was concussion codes that were deleted that you need to be aware of. In addition, there were some other codes I didn't add on here, but a number of codes that were dealing with bunionectomies and bunion management. If you do a lot of foot and ankle, those codes were changed and a lot were added to that. And then some of the X codes, there was a lot of overexertion or strenuous activity codes that were updated with a lot more granularity as well. Those are some of the things that you may encounter or you may be using in your practice. So changes, again, it's just, a total of 71,000 codes from the ICD-CM world. The guidelines that get published early on are really valuable and determine how the changes they publish, in the July, August timeframe are going to impact you. And if you don't have somebody working on that front office and more clinical each year, I really recommend you put process in place because the reactive approach and the denial is just challenging and really eats into a lot of cost, labor, and man hours we want to avoid. We knew there was a lot more laterality codes added with these updates that we saw the changes. And that's probably going to continue, particularly in the chapters, where we tend to spend a lot of our time or a lot of patients in the population in the M chapter and the S chapter, musculoskeletal and the injury chapters. So we need to be focusing and paying a lot of attention to that, and it makes it a lot more manageable. Hopefully, since the grace period ended, you've been tracking and managing your ICD-10 specific related denials, and looking, through your system or your software or even with your clearinghouse partner through denials management, because you want to be able to jump on top of that immediately so it's not impacting the ongoing recurring visits and causing you more and more denials when a simple code update, code change can help you accommodate and manage through that. And it's always good as you're doing utilization or chart reviews as well to make sure you're looking at the documentation and your documentation support your diagnosis changes. So what I'm seeing, but again, just one person, but the feedback I'm getting, I haven't seen where some maybe it's documented on a right knee and they coded it a knee, left knee, if that's been denied. Obviously, our software and systems has the ability to can mitigate against that occurring. But, I haven't seen, those types of simple errors where you coded it one way, but it was actually the other side. I haven't heard about that, but I'd expect that, the grace period is ending. Any way to review or deny, if it's based on documentation, inappropriate coding, we're going to start seeing more and more of that. And I'm working with our own revenue cycle team to do some work to publish more and more information on this through the rest of this year as we head into next year, to really help give you key areas to hone in on where we're seeing a lot of denial issues based on inappropriate codes from a ICD-10 perspective, and we'll make that stuff available to you guys. So, from a coding tips, again, just always be looking at, what are the number of codes per case? Do you overuse of the non-specific or unspecified codes? That's always a good thing to manage because we know the whole point of ICD-10 is really is to have a lot more specificity around the diagnosis of the patient and the presentation of the patient. And the continued use of non-specific or unspecified codes is just, should really be the exception and not the rule. And look at a lot of the high-use ICD-9 diagnoses prior to last October. Some of the top, 10, 20 diagnoses that were generating out of our space were all non-specific, unspecified codes. So I know the habit and nature is there, but we really need to get better at this, both front office, back office, and from the clinical owning that component of it. Again, monitor the denial rates by payer. You may start to see things that are unique, whether it's, edits they're applying, and diagnosis that they're starting to really not support. That, again, the grace period completely ended, and so it made it easy to make the change, but now I think we're seeing the pain, the change of switching to 10, kind of started October 1st this year. And then right on top of the LCD and NCD changes, we apply those automatically for our clients. But, make sure you see those, you're aware of what they are and how they may impact what you're doing in your practice and your coding. MACRA and MIPS, an interesting topic. I will tell you that I have read a bit of the final rule that got published, but I have not completely digested every single word of the 2,400 pages of this rule. There's some really good, I've got you links here and on the resources to the entire final rule to go over it. Also, I provided you some really good resources and really good executive summaries and some sort of one sheets that give you the high points of the final rule. And there's also a really nice reference document that shows here's what the proposed rule was and here's what the final rule was and here are the key changes you need to be aware of. So they're really good things to look at. So on Friday, October 14th, CMS published the final quality payments program rule out to us. And, not a ton of surprises, but, really, again, they listened to, over 4,000 public comments, engaged with 100,000+ physicians, people giving them feedback from the proposed rule. So we got a lot of input to the changes, and I guess the thing they heard most of was, race. This is a big change. We need to get used to managing through this, and disruptive. It could care to the patient and to the provider. So the intent, obviously, is to drive quality care through the two programs: the Advanced Alternate Payment Model, and then the Merit-Based Incentive Payment System (MIPS). For all the eligible clinicians and groups under the fee schedule. So it's really going to end up being very much a transition year next year. You'll see as we get into what they're attempting to do. So how do they be flexible, implement this as January 1st, but at the same time be flexible and looking at the choices I'll share with you. Choices the physicians have in their participation in this. It's kind of very much like some of the old PKRS components. So, where you have the opportunity I can participate and have the option to potentially get a really nice bonus 2 years later, or I can do the least amount I want to do to get my feet wet to avoid getting a penalty, or I cannot participate at all and I'm not worrying about it. I'm just going to budget to the penalty impact because I want to see how this thing goes. So you're going to see that approach not only for this year, and they're calling 2017 a transitional year, as they want to get people in the program and they're ramping up and taking a lot of feedback through the process. And then they're probably going to do the same thing in 2018, consider it a transitional year. So while it's a transitional year, they're still going to apply the performance, benefits and merit or penalties, later in 2019. So, but the focus of the program is really to encourage participation and a lot of education in capturing the data, submitting the data, and reporting driving quality. They basically came up with a number of options for the clinicians to participate in this, or the clinicians to participate. So, pick your pace. So, option one is really you can report MIPS for 90 days, or ideally for a year if you want to maximize your positive adjustment. You can just report for 90 days, but less than a whole year, and report to more than one quality measure, more than one improvement activity, or more than the required measures in the advancing care information category to avoid. And so, number two kind of gives you, here's the least you can do from a reporting perspective and avoid a negative payment adjustment. And I'll show you what those, are slated to be. Or option three is, choose to report one measure in the quality performance category, one in the activity improvements category, and report the other required measures in advancing care. So give you, again, kind of giving you a couple of different ways to do this. So again, and two, three are really, how do I avoid that negative adjustment, right? So, and the fourth option is clinicians can participate in the advanced alternative payment models and give a sufficient portion of their payments there, and will qualify them for potentially a 5% bonus in 2019. So the report mechanisms are, and it's providing the data, haven't changed significantly, and so that's going to be an evolving thing that we need to keep an eye on from a therapist perspective, because this is going really fast, or I believe is it going really fast. In 2019 is when we're slated to start to be participating, right? Impacting 2021 penalties or bonuses. So we need to have watchful eyes on this, and we will be doing our job here at Kasamba, and I will be always kind of keeping this in the forefront of your mind as to what we're seeing, how it's responding, changes they're making to this as it continues to continue to evolve. So when you look at the overall MACRA perspective, right, this is not just a quality payment program. It addresses, the fee schedule changes were part of MACRA, MIPS, as you know, and then the quality program and the advanced APM. So kind of here's that sort of calendar that's still in play as we see the 0.5% fee schedule, and we'll talk about the fee schedule a little later here in a second, but it's still slated to be a 0.5% each year, obviously for 2017 and the next 2 years. But keep in mind, well, that, right, their focus on fee schedule is always sort of a budget neutrality thing. So as you'll see, the new conversion factor is, not significantly changed, even though there's 0.5% up. There's some things that adjust that back down. Some of it is part of budget neutrality. So from a MIPS perspective, when you look at 2017, where the physicians will have to start reporting, so that have an impact to them either up or down 4% in 2019, and then it goes to 5% on their reporting for 2018 when they get to 2020. So what we need to be paying a lot of attention to is when we start having to report in 2019, we immediately are potentially impacted 7% up or down. That's a lot, because I know in talking to a number of clients and a number of people who were impacted by the PQS, particularly in the 2014 reporting period, where they included some additional treatment codes that PQRS reporting, which made the burden of reporting in 2014 a lot more onerous than it ever had been. They had added those codes for that year and then took them out. But more people in the therapy space failed 2014 reporting, had a 2% impact in 2016 on their Medicare fee schedule. And I know that depending on some clients and the percentage of Medicare patients you see, 2% was not insignificant. So imagine what 7% is. It's really more than 3 times that. So paying attention to this, being prepared for this, I will tell you here at Kasamba, we have teams we're putting in place looking at what MACRA means, what MIPS means, what the alternative payment models, how do we enhance the software to make it easier to report quickly, provide the core data elements as part of your documentation seamlessly so you're not having to do it, and mitigating the burden both from a clinical perspective, so it doesn't impact the patient, allows you to give quality care and provide the reporting you need. And changes do we need to make in the technology and in the system to make that easy. So we're heads down looking at that as we move forward, because we know this is coming, and it's coming faster than we all like. And then I saw one of the fourth options for the physicians was the participating in the advanced APMs, and that offers them a potential 5% bonus, which they can participate in. So I just wanted to bring that timeline back into you so you get a sense of it, and you become more aware of it. So simply from the MIPS timeline, this is zeroed in this. From this is really where we're going to be playing and living. Again, same thing. So reporting will start in 2019 unless something changes with a 7% up or down in 2020. So those adjustments, will begin in 2019 using that quality data. So again, very familiar. Unfortunately, it's still going to run that 2-year lag. So as you look at your budget perspective, you need to that's something you need to be factoring in, considering as you move forward. Okay, talk about probably the most important thing most of you dialed in on. So the physician fee schedule final rule. But, we didn't have a ton of surprises, but we've got, again, a link to the final rule. I think I've got some other resources that do some nice summaries, the key changes, again, from the proposed rule to the final rule and what these mean. And there's a flurry, I've seen a flurry of activity, webinars, and dialogue around, around the final rule itself, what it means, but specifically around the new eval codes, or the new CPT codes. I even talked to a number of people in the industry in our space and clients who kind of believed that the new eval codes wouldn't effective Jan 1, that would end up being like an ICD-10. It was something that they would just push it another year to as they move forward. But I know what this new administration is going to do as it pertains to the healthcare changes, Obamacare, MACRA, some of the things that are in place. But I know these are coming, and I know that value-based care, bundled payments, and changing the fee for service structure is just something that's coming, and we just have to start to adopt it and participate in making sure we're protecting the care we're providing. So I'll give you a little update on the payment rate update. We'll talk about therapy caps. They're still there in for another year. For sure, the CPT codes themselves, the new eval codes. I do want to also talk about with emphasis the misvalued therapy codes, because these new eval codes were identified previously historically as misvalued therapy codes, and that's why these new codes have come into play. One of the big reasons, and then an update on the telehealth services, etc. But the fee schedule, the final rate update. So I saw that sort of 0.5%, next year and the next couple of years is still in play. But again, you heard me mention the budget neutrality adjustment. So there's a target recapture amount, and then the imaging MPPR adjustment. So the net rate goes up. At the end of the day, it's kind of up like 5 cents. I think it was the 5.83 in 2016, so 35.88. They don't round up, unfortunately. Is the new conversion factor. And I do want to call out that I think in one of my previous presentations, I have incorrectly gave you, I think on the proposal, I may have had incorrect digit in the conversion factor, but the conversion factor is going to be 35.88 going into next year. So it's a little bit of an uptick, and a nice thing to continue to factor in. So you want to stay on top of that. But again, the budget neutrality is a whole big component of MACRA and what they're attempting to do. And so as they, as we eliminated or got rid of the sustained growth rate issues we had every year, this is certainly a better approach, and we don't have to worry about something forced through legislation between now and the end of March to mitigate some huge sustainable growth rate reduction. So talk about therapy caps. For 2017, small increase. I believe the 2016 cap was 1960, so bumps to 1980. Not a whole lot of changes here. So, the PT and speech is still a combined cap. The OT is a separate cap. As you know, the Medicare program pays 8% of the allowed amount. And the manual Medicare review threshold basically staying, at the 3,700 component. So those are good things. And there's some other things in the policy I'll talk about with regard to the cap and the threshold that I want you to be aware of as it relates to the eval codes too. Options process, or what we'll like to know is, when do I get to add the KX modifier? So still in effect, right, all the way through the end of December 2017. That was one of the other things that was addressed. So we'd have that ongoing every year. Is it going to be so? There's lots of legislation out there. And in the third quarter webinar, I talked about a number of different Senate and House bills. There's a couple of them that address repealing the cap altogether. Still watching and tracking those. It'll be interesting to see what happens to those or not. as we move into a new administration. And I'll keep you updated on those. I like to update those through Twitter. So if you do follow me through Twitter, I'll make you aware. So if we see anything on the cap between now and the end of the year, or as we get into the cycle into next year, we'll update you on that. But if your Medicare beneficiaries reach the cap and requires services beyond the cap, pending the modifier appropriately on the claims, will suffice. You do that KX modifier, it will pass any edits that are in place and will allow for payment for services above that new 1980 threshold. But you keep in mind, so when you're adding the KX modifier as a therapist, as a provider, you're testing that the services are medically necessary and that the services meet all the Medicare requirements for payment. It's kind of redundant to say, but I figured it was important to always say your documentation needs to support medical necessity for services. Now, you all know your documentation for a Medicare patient always needs to support medical necessity for services. So there's nothing special you need to do over and above the cap because your documentation always needs to support the medical necessity of services before the cap and after the cap. So, but it should be apparent as to why the patient needs to be continued to be seen and require those services. Guys, the adoption process really for any diagnosis or condition, which you can justify the services being medically necessary and continuing to need to see the patient, when you exceed the cap. That you're pretty familiar with. So one of the things MACRA did that was really good when it came to the cap was the manual Medicare review and some of the adjustments. So obviously, as you guys know, we had every went over the threshold for manual Medicare review was subject to review and burdensome paperwork and particularly when in the outpatient hospital setting, this was a big burden. And when you have a combined cap with speech and PT, it's not hard to go over that threshold given some of the patients we see, the variety of settings we see. So one of the things the MACRA did really was it eliminated that requirement for the manual Medicare review for all claims. Right? So instead did a targeted review process. And the other really nice thing was MACRA prohibits the use of recovery audits to conduct those reviews, right? So that's a good thing. Obviously, beneficiary exceeds that 3,700. It's that threshold just like the 1980 cap. So it's a 3,700 threshold for PT and speech, and it's a separate 3,700 threshold for manual Medicare review for OT. And again, it's based on the calendar year, so as you're all aware of that. But the things you want to be focusing on that, if they're still looking when they're doing their targeted review, when you go into the threshold, looking at inappropriate use. They're looking at the number of units and hours of therapy provided in a day. So they're going to be scrutinizing. Does every Medicare patient you see go over into the threshold? So they're looking for those outliers where they believe there's a pattern of behavior that warrants a targeted review, and to do that. So just have mechanisms in place to manage that effectively, and with the documentation as well as avoiding. You'll help yourself avoid those targeted reviews, and sometimes they're warranted, and sometimes it's fine, and the review process is successful from our perspective, meeting the needs. But just be aware of that. Those avoiding behaviors. Let's talk about the codes. So the PT eval codes, changes are effective Jan 1, and so real high level, right? So the 97001 is being deleted, no longer an active CPT code. It's replaced by 3 new codes, right? 97161, 97162, and 97163. I will tell you that we have some really nice updated cheat sheets. So there are one-pagers for the PT and the eval and re-eval codes, the OT eval and re-eval codes, and Megan makes those available as an attachment, and they're on our community for our clients as well. But make sure she makes those available as attachments to everybody who's on the webinar, so you'll automatically get those when you get a link to the recorded and a copy of the slides for today. So I want to make sure you've got some of those tools. Again, so you have this sort of low complexity, moderate complexity, high complexity. One of the big downsides to this, and you'll see it in my chart later, is they didn't change, is the RVU, the work RVU, is the same for each code, regardless of what you pick, right? So I think it's a work RVU of 1.2, regardless of low complexity, moderate complexity, high complexity. So again, one of the reasons they're doing this is getting a little bit more granularity and specificity on patients. When you're looking at value-based care, do you really take the same effort to do a simple post-op patient versus somebody who's highly complex with specific pain and symptoms and multiple comorbidities, very involved? Really the same evaluation, so you need to warrant and justify that. And we'll talk a little bit more about that. The PT reeval code 97002 is all deleted and replaced with a new reeval code, which is the 97164. It had, in the proposed rule, the RVU for it was 0.6 for the work RVU, and actually in the final rule it went up, so it was 0.75. So got a little up there. So that will help. And again, there's no reevaluation for establishing a plan of care that requires, review standardized tests and measures, revised plan with standardized patient assessment instrument and measurable assessments of functional outcome. So things we're used to doing and used to providing, those you need to start getting used to these, and I'll talk more about tips and some recommendations I have preparing for this. But you need to be preparing for this. If you haven't started already, you need to start and hit the ground running, at least post-Thanksgiving, to really prepare your clinicians for this and your back office from a coding perspective. So the new codes and kind of broken down by the components under each. So obviously the low complexity, when you talk about personal factors and comorbidities, I believe I referenced below, when you're ever talking about comorbidities, it just, it's the comorbidities that are going to impact your ability to treat the patient and have a successful outcome. So some may have a comorbidity that may have no impact. It really doesn't factor in something that would justify a change in the code itself. Body parts and functions. So when you look at body parts and functions, really all of this is pulled from the International Classification function, right? So using the ICF, and we're all familiar with the ICF, we're starting to get familiar for some of these who weren't before with the functional limitations reporting, because all of the functional limitation reporting elements, say on the PT side, came from ICF. So I've included a link to the ICF browser, and where you can see, and they provide a lot of detail with respect to what body parts, what functions, functional mobility, and the categories, because we're going to see, I wholeheartedly believe, again, this is opinion, that the interesting function is going to be the way in which we look at and categorize patients and drive function and outcome more and more so. And then component of stability, it's really, your assessment of the clinical, your clinical assessment and judgment are the factors that are impacting that patient to be able to work through the plan of care and manage through that. So stable are they from those perspectives? And then obviously your clinical decision making, right? And so a key component of how complex is it? Is it somebody who again walks in the door post-op, younger, lack of comorbidities, good clinical reasoning, but it's not complex. It's relatively straightforward. It's a little bit more something that may fit into a very nice protocol approach. That's kind of where that's lending itself to. The other component is the time component, which has kind of freaked everybody out, right? So do I have to document and justify the amount of time? And everybody, regarding the coding and the AMA and everyone that I've talked to regarding this is just meant to be a guideline, right? It's not, there's no hard and fast rule. You have to document that you spent at least 20 minutes face-to-face with the patient or the patient's family in order to justify this eval code. And so, don't as a burden. It's again meant to be a guideline. If it's a relatively low complex patient that's presenting to you, then you probably shouldn't be required to spend more than 20 minutes face-to-face with them or their family. And so it's a guideline. Don't be overly worried about that. The other thing I wanted to reference here, and I'll do OT ones as well, is you have patients that no patient's going to fit perfectly sort of along each row, right? So you're going to have a patient who's relatively low complex, but they may have two comorbidities, and they may have a little challenging, from stability or clinical capabilities to progress. And so the question is going to be, you're going to have to sound clinical judgment as to when you go to sort of that next complexity. But I'll talk about this again in my coding tips. Avoid this because somebody has three comorbidities, that they're automatically a high complex patient, because that's just not true, right? And so, and we want to be looking at that as you're documenting and selecting the appropriate code. And I'll talk more about that as well. We'll talk about, as I said, body region, body systems, body structures. So the body region, systems, and structures, a lot of that stuff, as I said, it's coming from an IF perspective. So the region, head, neck, back, extremities, trunk, etc. The body systems, cardiovascular, pulmonary, integumentary, musculoskeletal, etc. Which systems are being impacted, or multiple systems are being impacted, which can come into play for a lot of our sort of general medical and stroke patients, etc. And body structures, all the different. But when you think of body structures, don't just think about the musculoskeletal structures. Think about stuff like the kidneys, liver, diabetes components, and so there's other component structures that can have an impact, care and on their ability to be successful that you really want to be able to, take into factor. And then personal factors, which sometimes, we don't take enough, don't leverage enough for a particular patient. Obviously, depending how young they are, and the, in structure they come from, but social background, the environment, the home environment, support do they have, their overall attitude toward getting better, their motivation. A number of these things can really drive and have an impact on someone's ability to, to be successful or to be successful relatively quickly and be a less complex patient. OT codes, same thing, right? So OT 9703 deleted, 3 OT codes, 97165, 166, 167, moderate, high. A little bit different components. We'll talk about that in a sec. And again, those are all on the cheat sheets that we'll make available to you. And then on the evaluation code, 9704 deleted, and we're with the new OT reeval code. That's 97168. And so nice, they're all in sequence. And similar things from a reeval perspective, right? Assessment of changes in patient function, medical status, update occupational profile to reflect changes in the environment or interventions and goals, and then a revised plan of care with a part of any formal evaluation documented change in status or changes that would be significant where a new plan of care is required. So relatively straightforward. I want to make sure I didn't jump slides. So with the components for OT, we talked a little bit about these on the proposed rule. There's some differences. Same, low, moderate, high, but then we have performance deficits, and when we have the clinical decision-making is the same. Comorbidities, sort of a separate category of non-effect, will affect, and kind of to meet even a level that they're numbered in the PT1. That's the real thing, right? Where, as I said before, will the comorbidities impact this episode of care that I'm treating the patient with, and does have an outcome on how successful or how complex it's going to be. mod adjustments you have to make to complete the eval. So what's going on, right, with the patient, and I'll talk more about that in a second, that may make it much more challenging. Are there, are there factors, there could be personal factors, it could be other factors that come into play with respect to this. And time, again, a little bit different time. So instead of 20, it's 30 here, 45 and 60 for low, moderate, and high. And again, no requirement that I've seen that has to be a documented time element within the within the documentation itself. But again, it's a guideline that based on a low complex patient, you shouldn't be spending much more than 30 minutes time. So that doesn't mean if you spend 38 minutes that you automatically go to a moderate. Again, this is where you really need to do some, real case studies and look at how would you categorize, a number of these patients, and I'll talk about some of those examples in a second. I did stumble across on the AOTA site. They have a really nice little overview of the new eval codes from a OT perspective. And so there's a link here, and I think I included the link on the resource, but it takes you right to a really nice PDF. So if you have a lot of OTs or if you're prominently in OT practice, it's really good because it's very specific to practice and evaluation of these codes. There's some really good, I really like how they broke it down. It's not a long document, it's very easy to digest, and I think it makes a great training tool within a clinic, et cetera, that you can leverage. So just like we did with the physical therapy codes, so the OT codes, so one of the big categories is sort of this performance deficits, and I jump back. So looking at that third component where it's 1 to 3, 3 to 5 or more, this is sort of, giving you a little bit more detail. I think some of this may be called out in that OT guide, or at least they allude to it. So what do you mean by performance deficits? Right? So the ability to complete activities due to lack of skills in one or more of the categories or areas below. So are there physical impairments, body structures or function? It could be everything from balance, strength, to other body structures or body functions that are a problem for someone to be able to have impact on their performance. Their cognitive skills. So see this, much more the occupational therapy world, but also impacts P. Can you attend? Can they think? Can they problem solve? Can they sequence things? In a safe and timely manner, right? And looking at, again, not just the structures, but the organs and other systems of the body that could be impacting that. And then social skills. So interpersonal skills, habits, routines, motion, how do they cope? How do they adapt to their environment? What kind of environment are they coming out of or having to work in or live in? Is that impacting their everyday situations that will impact their performance deficits? So this is really good to be thinking about, particularly when you get into that sort of numerical ranking of how many performance deficits someone would fall into. So again, sort of, I guess, good news or bad news, depending on if you were thinking they weren't going to be effective in January 1st. So new eval and new eval codes are effective Jan 1, right? So the old evaluation and reevaluation codes are going to be deleted. The thing I want to make sure is clear on, right? So this is like the ICD-9 to ICD-10 change. So just like ICD-9 to 10, all HIPAA-covered entities had to adopt ICD-10, whether you want to or not. But you also know there was a number of non-HIPAA-covered entities who did. They could still stay on ICD-9, and we had to manage possibly sending 9s to them and to the HIPAA-covered entities. Well, the same thing is possibly going to occur here, and I think it will occur based on feedback I've heard. So this does Medicare, right? Pretty much all your commercial payers, Cigna, UnitedHealthcare, Humana, Aetna, Anthem, Blue Cross Blue Shield, right? I kind of got a list below. It also includes the state Medicaid programs, et cetera. But again, sort of, who doesn't it include? Well, it doesn't include, it means they don't have to adopt these codes. Long short-term disability patients or comp, or worker comp-like insurance, right? So automobile, auto, legal, all for that. So liability, general liability stuff. So none of those are considered HIPAA-covered entities, and if you have patients being seen, and probably mostly either in the auto, legal, or work comp area, you want to make sure you're submitting. You need to validate with them. Will they be accepting the new codes? I know someone, a friend of mine, reached out to work comp in the state, asked them about the eval codes, and they had no idea there was any new eval codes. So they kind of basically said, look, no, we're reconsidering our PT eval to be 97001. And so you have to have the ability to know to do that. Now, luckily, we've made changes in our system that the therapist just documents an eval, chooses the correct, level of severity, and we take care of that for you, right? So if we know it's a work comp, it still needs 97001, we'll pass the 97001 code to them. If it's a covered entity, they'll get the appropriate code based on the level of complexity that is chosen by the therapist on that evaluation. So we're trying to take this work out of it for you from a therapist perspective and have those coding rules that are generated based on your documentation all taken care of for you. Also, we're filling up some training and educations that I want you to be aware of, because I know there's a number of clients on the call. So some training and education materials, as well as some recorded modules, et cetera, about how to do this exactly in our system and then what this is going to look like. If you have not, we published a new clinical knowledge base update that has all of the ICD-10s and also the new eval code qualifiers for the low, moderate, and high complexity patients all in there. And so if you haven't had that update, you need to be reaching out to our client services team and get a schedule to get updated so you're well prepared for this. But what you have to do is once you get that update, we kind of take care of the coding for you, and we're going to be applying, giving you some training materials you'll see here very shortly available that you can use and leverage just particularly how the system is going to do it and make you aware of that. And if you're using our system, please be reaching out to your other vendor systems to what do they have, how are they handling this. Don't wait to the last minute to figure out or trust that someone is going to do this for you, because you don't want to end up with a lot of coding issues or denial issues because you're not using the right codes. So the biggest thing to know is they're active Gen 1 in owned entities. I would covered entities, whether they're going to adopt the new codes or not. I would expect that it involves changes they have to make significantly, and my opinion is a lot of the non-covered entities will not be adopting these codes yet. So that's something to stay on top of, particularly if you do have a lot of auto, legal, workers' comp, or patients who fall into that criteria of non-covered entities. Coding tips, I would immediately, now we know these codes are here, and we know sort of the components of each of the codes from PT and OT perspective, focus mostly on the evals, because the re-eval is pretty straightforward, and there's only one to choose from. Start practicing now. Pull out a bunch of current evaluations or recent evaluations you've done that you think are interesting, and do a lunch and declare at the clinic or run through some scenarios, how everybody code this, low, moderate, high, and then talk about why. I think start to build some consensus, right? It's obviously to some degree they've tried to make the components very objective in nature, but we all know there's a subjective component to it, and as therapists, we all see things a little differently. I know the ETA is going to be putting out some clinical vignettes specifically around this, and so I'd be looking for those for guidance. There are some other ones out there, but I would even create some of your own scenarios. It's great to get with staff to do this because you know your patient population better than anybody else does. You know the types of patients you typically see and what they typically present based on your referral sources and the patients that come into your practice. So you're the best at doing this and putting this together, and I think it'd be really good. The thing I put in is avoid choosing the safe choice. What I mean by that is because the RU is the same, which means you're not going to get paid any differently. Avoid I'm just going to pick low. Could this to be a problem down the road when they're finally going to start using this to audit me or whatever? Or I'm going to be even super safe, and I'm just going to pick moderate every time because I can justify it probably up or down really easily, and just always pick moderate. Good thing. And it's not a good thing for a number of things. We all know, even although the RVU is the same and they're going to pay you the same, how they're going to use the data, and they will use the data. They use the data at PKRS, they use the data on functional limitations, they're using the data in the ICD-10 changes we've already seen, and they're going to use this data as we move toward more value-based care. We have the payment model changes coming that we're going from fee-for-service to probably encounter-based payment system to a full episode for the entire case will be paid something, right? And so we may for the encounter, but that's probably where we're going. And everything we've heard and everything I've heard, that's where we're going. So you want to be careful about what you pick, not just because you're going to be scrutinized of what you documented in your eval. Does it match with the appropriate moderate complexity? But if you say somebody is a low complexity and you see them for 18 visits, you're going to start to look at the number of visits associated with a low complexity patient. And I'm concerned about that component down the road. Well, you said they were not complex. Why did it take you so long to improve their function, right? They're going to draw, when we look at this data and the data gets looked at, that's what I'm concerned. I'm more concerned about the overall cost and impact to my case, my overall patient visits, not just my eval, right? And so I want to be conscious of that as you're making these decisions and you're teaching your staff and you're training your staff, because a whole bunch of high complexity evals, and they're treated and charged in 3 days, 3 visits, that's going to be scrutiny. So again, can't emphasize enough. Don't just look at, did my documentation support the eval code or not, and look at that narrowly. Look at it. It's going to be looked at across the entire episode of care and what impact that may have to your practice, to us in the industry going forward. Because there is a parallel there that, in my opinion, again, and you're going to probably hear more of that from some other folks. The other way, choosing the higher complexity eval code just based simply if it, one component, so again, what I talked about earlier, hey, they have, they've got a couple of comorbidities, so immediately I'm at a moderate, or, you're going to have people who are not going to fit perfectly in each bucket, and everybody understands that. And so as you go through, looking at current evals and current patient types, or go through vignettes, there may be some debate. It's not going to be, it's the wonderful art and science of our practice, right? So, there may be some debate, but at least if it's debatable, it's good. But if you're automatically jumping, the perception of upcoding could come out, and you don't want to get into that. The physicians went through that with E&M coding, and those are things we want to be aware of. Finally, on the coding tips, make sure you're looking at, if you're setting or supporting comorbidities and stuff, have you added the ICD-10 codes that reference those comorbidities? So do those codes exist? I think we've gotten a lot better at that over the last year, but those things you also want to be looking at. Getting near time, but so misvalued. So that's enough on the coding stuff. And I said, look cheat sheets from us that'll come with the recording of the webinar and the deck. Also, there's going to be some training and education materials for your class on the community that we're making available, specifically in some changes we've made to accommodate, to make it easier to adopt the eval codes and the re-eval codes, so look for those. The valued codes, so there was 10 identified, and again, remember the eval codes and the re-eval codes were previously identified as misvalued codes. So potentially misvalued codes, there's 10 of them in therapy, and I*Therex, because 97110 was one of the most valued in their impression. So you've seen a lot of dialogue because there's a reevaluation, there's an evaluation period coming with the AMA RUC in February, and they're going to be looking at a lot of data, and they're going to be looking at these potentially misvalued codes. And so there's a survey, there's a RUC survey and they're going out to a sampling of members of APTA. And APTA is repeating the drum, and I applaud them because, and I've been doing it too, that if you happen to be one of the members who were surveyed and respond to the survey, because come the meeting in February, may end up deciding which of these codes are going to be impacted, reevaluated, etc., in the physician fee schedule for 2018. And all these codes, particularly Therax, therapeutic activities, and NeuroRead, are high, and GATE and therapy are high used codes in our space. And so we have to be active participants in defending and justifying our codes. And when surveys get put out, don't ignore them. If you're surveyed, you have an obligation, I believe, as a therapist to your practice and your industry to respond to that survey. And again, we'll keep you posted. I'll keep you posted what I find out about that RUC meeting in February. It's kind of a closed door thing, but we'll see what we're hearing. And we'll keep on top, obviously, of these codes. The telehealth update, obviously, unfortunately, the CMS didn't change its position on telehealth and didn't add PTs or OTs as authorized practitioners in telehealth services at this time, and basically said it would take some congressional action or some legislation to address that. There is a bill, and I referenced it in the Q3 regulatory webinar, that helps promote the telehealth services from an outpatient rehab perspective or from a rehab perspective, and I believe there's inherent value in that. So I'll be keeping you updated on that specifically as we move forward, because I believe that's something that may get addressed in legislation. I just don't know with the changes in administration. Again, we'll keep on top of that. Just some up finances. I know we're kind of at time. There's a webinar scheduled, and it looks like it's going to be really, really good content the TA is doing. Medicare payment compliance, what you need to know for next year. It's going to cover a lot of the rule schedule stuff. Heather Smith and Rashonda are putting it on. A number of verticals, right? Skilled nursing, home health, as well as the outpatient space, hospital space, etc. Usually really good material, good reference stuff. It is free if you're a member of APTA. There's no cost for you to attend that webinar. I stay an active member. That's your choice or decision, but with all the regulatory things coming, I think they do a pretty good job in providing information and guidance. I think that's worth it as well. But I don't think it's very expensive if you're not a member. But again, I think it's another good way to get education and hear from another source. There's going to be a lot of dialogue and topics about all these changes, obviously with the administration changes and what's coming with MACRA, and you'll see at the APTA CSM conference, and I believe that one is in San Antonio there. I thought Megan, who's my counterpart on the marketing side, we're going to be trying to do a little bit more blogs, and we're going to try to be doing more articles very specifically around payment model changes, MACRA changes, how they'll impact us, how we can best prepare for those number of things, and a number of the topics. Because I like doing a big broad one like this in the quarter to cover a lot of material. But I think we're going to start doing some more tactical ones and make those available, even if you can't attend, since we record them all, put them out there for you guys. And love to have your feedback with respect to, would you like to see deeper dives, like an entire webinar just on the eval codes with vignettes and stuff? Those are things would be interested in doing, or knowing your feedback on them if you find those to be worthwhile. Just wrapping up. I've got a couple of additional resources I wanted to put out there for you, but from an ICD-10 perspective, there's a number of really good resources for you on the proposed fee schedule, GA, CMS, etc. Then the link to the ICF browser, which is really good to go out and look at that, because that's if you're not familiar with that, you really need to get familiar with the ICF. Both HIMSS has a lot of good information, even if you're not a member, and they summarize things really well. And so it's good. And then CMS, their quality programs, all the information on the final rule, the executive summary, et cetera, to stay on top of those. And you want to wrap it up?
Sure. Thank you guys for staying with us a couple extra minutes. So with the change over to Kasamba, we've got some new places for you to follow and places for you to find information. To learn more about our company, you can visit us at kasamba.net. And if you can always follow us on social media, we're on LinkedIn, Twitter, Facebook, and Instagram. And of course, you can follow David for more of the minute updates. He's on at @D_McMullen, and that's McMullen with an A-N. Again, thank you so much for joining us. We'll be sending out an email with a recording of today's presentation. The quick guide I mentioned earlier about the new codes, as well as a copy of the slides. So I hope you guys enjoy the rest of your day and enjoy the upcoming holidays, and we look forward to having you guys again Q1 of next year. Thank you.